Systemic inflammatory response syndrome, or SIRS, is an inflammatory reaction in a site remote from the original insult. In order to be diagnosed as SIRS, you need to have two of the following symptoms: temperature that is less than 38 degrees centigrade or greater than 38 degrees centigrade or less than 36 degrees centigrade. A heart rate greater than 90, respiratory rate greater than 20, your PaCO2 of less than 32, and a white blood cell count of greater than 12,000. Remember that your normal inflammatory response starts in seconds and lasts a maximum of 8 to 10 days anytime somebody receives an insult of any sort, physiologic or psychologic. SIRS is due to an infection. It's then called sepsis. There's a box on page 1004 that talks about the symptoms you must have, but the temperature has to be greater than 38 or less than 36. It can lead to multiple organ dysfunction syndrome if you're unable to control the infection, inflammation, persistent hypotension, increased oxygen demand, and the presence of necrosis. When somebody goes into septic shock, they have sepsis-induced hypotension despite the fluid replacement that you give them. So regardless of what you do for them, they still have hypotension. Multiple organ dysfunction syndrome can be called, is failure of 3 or more organs and has about an 80% mortality rate. In 1988, the mortality rate was 60 to 80%. So we haven't made a huge amount of progress here. And if they survive MODS, they usually develop COPD. Risk factors are SIRS, trauma, elderly, and then other things happening with them, shock episode, or burns. Usually the lungs are affected first. That leads to ARDS, and that's why when they survive the event, they usually develop COPD. You'll have hypermetabolism that lasts 14 to 21 days. Symptoms are a decrease in body mass, a decrease in weight loss, weight loss, not a decrease in weight loss, but weight loss, and an increase in cardiac output, an increase in the amount of oxygen that is used. Your renal and hepatic failure become pre-terminal events that may occur. Now, pathophysiologically, you'll have maldistribution of your circulating blood volume due to increased capillary permeability, vasodilatation, and vasoconstriction in the organs, such as the lungs, the kidney, and the GI tract. That puts the patient at risk for ARDS, acute renal failure, and ischemic bowel syndrome. And oftentimes the source of the infection is the abdomen. There'll be an imbalance between oxygen supply and demand that can lead to acidosis. It can cause abnormal metabolic control, which will increase your metabolism. You'll have hypermetabolism. With hypermetabolism, you have an increase in oxygen demand, increased protein breakdown. Your immobility will also cause protein breakdown and muscle atrophy. 25 to 40% of the patients who die will do so in the hypermetabolic state that occurs. Normal cell mediators will cause damage to the healthy cells, causing an increase in free oxygen radicals, and there's a box on page 1007 that talks about these. Your tissue necrosis factor alpha, or cachectin, occurs in increased amounts, causing widespread destruction, causing fever, hypotension, decreased perfusion, and increased capillary permeability. By stimulating the clotting cascade, it can cause disseminated intravascular coagulopathy, interstitial pneumonitis, acute tubular necrosis, and necrosis of the GI tract, liver, and adrenal gland. And they'll also have hyperglycemia. And these factors are discussed on page 1008 in a box. Interleukin-1 will decrease blood pressure, cause fever, tachycardia, diarrhea, lung injury, low white counts, platelet aggregation, and DIC. Platelet activating factor will cause ischemia and increased vascular permeability and an increase in vasoconstriction, which will cause platelet aggregation and cause microvascular stasis. So you have clotting that can occur. Again, helps with the DIC. Helps to cause the DIC. Arachidonic acid metabolites cause vascular instability and maldistribution of your blood flow. An example of one of these arachidonic acid metabolites is thromboxane A2. This causes vasoconstriction and increased capillary permeability. Prostaglandins are also released, and they cause the vasoconstriction, the increase in capillary permeability, and platelet aggregation, so that'll lead to increased clotting. And leukotrienes are another one, and they cause the platelet aggregation, vasoconstriction, increased capillary permeability, and vascular leakage. Page 1006 lists the whole patho for this process. Symptoms are in a box on page 1010. But some changes that can occur by system. Now remember that your GI system contains normally 70 to 80% of the immune tissue of the body. So the GI system will have decreased perfusion, so you'll have mucosal damage. They don't eat as much, so that disrupts the normal protective measures. Normal bacteria enter the systemic circulation and increase the inflammatory response and damage to the liver cells. Now the liver, which is extremely vascular and receptive to ischemic injury, causes hepatic insufficiency. So you'll have jaundice, an elevation in your AST, your bilirubin. You'll have an increase in red blood cell catabolism or breakdown. Your gallbladder, you'll get an acalculous cholecystitis 3 to 4 weeks after the hypotension, with the symptoms of right upper quadrant pain, tenderness, abdominal distress, unexplained fever, and absent bowel sounds. 50% of the patients will have gangrene of that gallbladder, and 10% will have a perforation that may occur. Your pulmonary system, you'll develop acute lung injury or acute respiratory distress syndrome, 24 to 72 hours after the injury. You'll have a low-grade fever, dyspnea, confusion, an increase in your heart rate, and increased metabolic needs. Your body will feel as though you've been running the 8-minute mile 24 hours a day for 7 days a week. That's a lot. Renal system, acute renal failure is common. They may require dialysis. Cardiovascular, they'll have myocardial depression leading to cardiogenic shock. Your nursing diagnoses are found on 1012, as well as the collaborative treatment for that. The evidence-based practice for nutrition is on page 1013. And the experimental approach is on page 1014. DIC is disseminated intravascular coagulopathy. There's a figure for this on page 1094 for your patho, and it also contains another box that has the symptoms. Treatment: pulmonary artery catheter to assess hydration status and the cardiac output. You want to decrease that oxygen demand by sedating your patient, maybe having them on a ventilator, maintaining temperature and pain control. You want to maintain oxygen supply with a normal hematocrit and PaO2 levels, so you may need to use PEEP and fluids to increase preload, increase contractility, and decrease afterload to increase that cardiac output. Nutritional and metabolic support are really important. And prone positioning helps to improve oxygenation. You'll find the key labs for this on page 1095, causes on 1093, bleeding precautions and nursing diagnoses on 1096, and collaborative management on 1097. Thrombocytopenia is when your platelet count is below 140,000. It tends to affect females more than males between the ages of 20 and 50. Your symptoms are on page 1097. Your treatment are your steroids and your IV immunoglobulins. Maybe a platelet transfusion and surgical removal of the spleen if it doesn't respond to anything else. Your nursing diagnoses are on page 1098. Heparin-induced thrombocytopenia, or HIT, used to be called white clot syndrome, and it's the clotting of your platelets. You can see the pathophysiology for this on page 1098 with the symptoms on page 1099. It can cause heart attack, stroke, pulmonary embolism because your platelets are clotting. Medications that are used to treat this are on page 1100. I forgot 2 zeros there. Your nursing diagnoses are also on page 1100. Your patient education is on 1101, as well as your collaborative management is there. Tumor lysis syndrome is occurs when you have metabolic changes due to cancer treatment. The breakdown of those cancer cells actually releases potassium, phosphorus, and uric acid into the system, and so you end up with hyperkalemia, hyperphosphatemia, and elevated uric acid levels. This occurs most often with leukemia, lymphoma, and metastatic diseases. Symptoms are on page 1102, treatments on page 1103, and your nursing diagnoses are also on page 1103. And that finishes this lecture.